That was our broad overview of the urinary system. Now it's time to get into the details. What do you say? That was pretty detailed already? Well, just wait. There's a lot going on in the urinary system. Here we see the anatomy of a nephron. A nephron is the functional filtration unit of the kidney. It's composed of a renal corpuscle and the renal tubules. The majority of it is located out in the cortex, with the loop of Henle and the collecting ducts traveling down through the medulla. The Bowman's capsule is seen here, and it's formed with two layers. First, we see the visceral layer. The visceral layer is a layer of cells that wraps around the capillaries itself. On this side of the capillaries, the visceral layer is present. On this side, it's been stripped off, so we're able to see the naked capillaries. The parietal layer is shown here in purple cells lining the Bowman's capsule. And the capsular space is the space between the two layers, between the visceral layer, which coats the capillaries, and the parietal layer that lines the inside of the capsule. The space in between is where that filtrate is going to be collecting. Here's a little different view that shows us all the different cell types that line the proximal and distal convoluted tubule. Here's the glomerulus with its afferent arteriole and efferent arteriole. Filtrate will be produced inside of the capsular space and fed into the proximal convoluted tubule. Here we have specialized cells that are going to be reabsorbing a lot of that secretion. As it travels, it enters the loop of Henle with the descending limb coming down and the ascending limb coming up. We reach the cortex again as the distal convoluted tubule, which connects with a collecting tubule that feeds into a collecting duct. Each section of the tubule absorbs different solutes and different amounts of water. So as the filtrate travels down, we might absorb more calcium in the proximal, more sodium in the nephron loop, maybe more excess water in the distal. The reabsorption can vary based on what section of the tubule it's in. By the time it gets here, now it's urine. There are two types of nephrons. These nephron types are divided by their position of the corpuscle in the cortex and the length of the nephron loop. One type is called the cortical nephron. 85% of nephrons are this type. If you look on the model, the loop itself does not go very deep into the medulla. In comparison, a juxtamedullary nephron, about 15% of nephrons, has a long loop that travels much further down into the medulla before coming back up. Juxtamedullary, cortical. Now that we know the basic components of the kidney and its many nephrons, let's find out how the body makes urine. First, we know that blood plasma needs to be filtered out of the capillaries. Pores in the capillaries allow the exit of fluid, and the next slide will look at the capillary membrane in detail. This right here is our capillary membrane. Here's the inside of our capillaries, full of large red blood cells, white blood cells, some platelets, some large proteins. On the outside, we have the capsular space where our filtrate is located. Our filtrate is going to be composed of water, glucose, amino acids, ions, urea, hormones, vitamins, all very tiny substances. Whereas the large substances like white blood cells and red blood cells are being contained inside of the capillaries and don't leave and enter the capsular space. We make this filtrate, which is basically just filtered blood plasma, by having very tiny pores that only the filtrate is able to escape through. Our capillary wall is composed of three layers. The endothelium layer is the innermost, making up the walls of the capillary itself. Then we have the basement membrane. These very small pores only allow tiny proteins and then just the dissolved solutes in the filtrate to pass through. Lastly, we have the visceral layer. Now the visceral layer from this cross-section view just looks like hills. sideways hills. On the next slide, we're going to see what it looks like when all of this visceral layer wraps around the capillaries. These are specialized cells called podocytes. Here we see a capillary and another capillary. These capillaries are surrounded by the specialized cell called the podocyte. On this picture, we only saw the little tiny extensions of the podocyte. And here we see how it looks when you see the entire podocyte cell wrapping itself around the capillaries using these extensions. The extensions have an almost feather-like edge, and they fit in like basically a lock and key fit with the next extension, forming a tiny little filtration slit or an opening between the two. It's through this tiny filtration slit that any filtrate is able to squeeze through. So our podocytes surround our capillaries inside of the glomerulus. This picture shows us a close-up view where we can see the endothelium layer of the capillary. This layer is not very thick and it has these pores that allow maybe a medium-sized protein to go through. We can see right here they're coming out into the capsular space. But next up, there's a layer of basement membrane. This one has smaller openings, and then if it can fit through the basement membrane, the filtrate also has to squeeze through the tiny filtration slits of the podocyte. This is the visceral layer that we talked about. So you can imagine that nothing too big can squeeze out of the capillaries into the capsular space. This picture is a scanning electron microscope view of the visceral layer of the glomerular capsule. So our podocyte cell, with all of its little foot-like extensions, surrounds and wraps around the capillaries that form the glomerulus, a ball of yarn. Here's another cell wrapping around the capillaries, another one. Here's a close-up view showing us all those little, almost feather-like extensions. You can see that the filtration slits are pretty small and don't allow a lot of filtrate to come through. Here's an even closer view of the visceral layer. In your kidneys, you are producing 180 liters of filtrate every day. But do you happen to recall the amount of urine you're producing every day? 1.5 liters. Whereas we're producing 180 liters of filtrate. Yet only 1.5 liters of urine leaves our body. That can kind of give you an idea of how much of this filtrate we're reabsorbing and how little you're actually urinating. This slide helps us categorize all of the substances that are coming out of the capillaries into the capsular space. Small substances like water, glucose, ion, urea, these are all going to be freely filtered. They can just pass freely through the membranes. We're going to see a tiny limited filtration of small and medium-sized proteins. Sometimes they can just manage to squeeze through that basement membrane and the filtration slits. Whereas these large proteins and all of our formed elements like white blood cells and red blood cells and platelets are not going to ever be able to squeeze through those membranes. So you should not see those in the filtrate. The amount of filtrate that we produce depends on a pressure gradient called filtration pressure. Just like a hose with a hole in it, the greater the pressure inside of the hose, the faster the water will push out. Another good example is a water balloon. If you were to fill a water balloon up to just almost until it burst, and then poke a hole in that water balloon, you probably can imagine how fast that water is going to be shooting out. But if you put a little bit of water in a water balloon, it's not stretched, it's not taut, it's just there, and then poke a hole in it, it'll just kind of leak out. There's not a lot of pressure behind it. So in the same way, the amount of pressure inside of the capillaries is going to directly be related to the amount of filtrate that's being pushed out of them. The more pressure, the higher it goes, the faster the filtrate is being pushed out of those capillaries. The more filtrate we produce, the more urine we produce. When we have low pressure inside of the glomerulus capillaries, we're going to reduce the amount of fluid that comes out of the glomerulus. Say we constrict the afferent arteriole. When we do that, we're going to decrease the amount of blood that enters the glomerulus. Well, we're not stretching the capillaries, so they kind of shrink a little bit, like a small water balloon. Because it's not that pressurized, we're going to see a little bit of filtrate come out. It's going to decrease it from what it would normally be. Most of your blood plasma is just going to leave through the efferent arteriole. If we have high pressure, that's a different story. Dilating the afferent arteriole allows more of that blood to enter the glomerulus to the point where this thing is highly pressurized and we are just shooting filtrate out. So we have a very high rate of filtration occurring. This is then going to go push into the tubules and we're going to see more urine production from this. We have some special terms for this pressure. It's called glomerular hydrostatic pressure. This is defined as the pressure inside of the capillaries of the glomerulus. This is pushing fluid out of the glomerulus. This picture had low hydrostatic pressure because there's not a lot of blood flow coming in here, low pressure. This picture shows us high hydrostatic pressure. Because of that, we're going to be pushing out a lot of filtrate. So glomerular hydrostatic pressure is the pressure inside of the capillaries pushing out into the capsular space. The higher the pressure we have here, the more filtrate we're going to produce. In direct opposition, we have capsular hydrostatic pressure. Capsular hydrostatic pressure is the pressure of the fluid filling the capsular space. If this area becomes highly pressurized, it can actually stop fluid from exiting the glomerulus because there's so much pressure surrounding it in the capsular space. We also have an effect by the blood osmotic pressure. Now, let's try using the glomerular hydrostatic pressure inside of the capillaries pushing out and the capsular hydrostatic pressure, or the space of the filtrate in the capsular space trying to stop the fluid from leaving. And if we compare these two, the one whose pressure is higher decides where the filtrate will go. If the glomerular hydrostatic pressure is higher, the fluid will be pushed out of the capillaries into the space through the tubules. If the capsular space has the higher pressure, it's going to stop that fluid from leaving the glomerulus. Here we can actually look at the measurements for it. Here's our glomerulus with a glomerular hydrostatic pressure of 60 millimeters of mercury. This is the pressure of the fluid pushing out of the glomerulus. In direct opposition to that, we have some capsular hydrostatic pressure, which is just 10, and also some blood osmotic pressure. That's the pool, basically, of all of the formed elements in the blood and the proteins pooling the fluid back into the glomerulus. Combined, this pressure is only 20 millimeters of mercury. In this example, where is the fluid going to go? We have much higher pressure trying to push out of the glomerulus. So because of that, the glomerular hydrostatic pressure is winning here, and it's coming out of the glomerulus. So we're producing a lot of filtrate right now. If we change it up, ooh, yeah, the glomerular hydrostatic pressure is pretty low right now. It's only 20 millimeters of mercury. In comparison, our capsular hydrostatic pressure is 30 and our blood osmotic pressure is 30. In this case, fluid's going to be going into the glomerulus more than coming out. So we're not producing a lot of filtrate right now. Here's a diagram showing us that again. Here's the afferent arteriole. Blood enters the glomerulus. Our hydrostatic pressure is 60, trying to push out of the capillaries. Osmotic and capillary space is going to be combined, pulling into the capsule and trying to push the fluid in. We only have an opposition about 50. Because of this, our net filtration pressure is going to be 10 out, and we are producing that filtrate. It's interesting how you can actually look at the measurements for this and say, why is filtrate coming out of the glomerulus and why is filtrate being pushed or pulled into it? These numbers are going to change all day for you. If you drink a lot of water, if you start to run low on electrolytes, if your blood pressure goes up or down, all of those things are going to be affecting these pressures. So your body is continually regulating them and modifying them as needed. Your kidney is being controlled or innervated by both the sympathetic and the parasympathetic nerves. Your sympathetic nerves innervate your kidney blood vessels, so the renal artery, how much blood is going to those nephrons, the JG apparatus that we see in lab, and it decreases urine production if needed. The hydrostatic pressures influence the rate at which filtrate is produced. We can look at this as the glomerular filtration rate. It's a measurement of how much filtrate is being produced, and it's useful as an estimate of kidney function. Healthy kidneys are going to have a glomerular filtration rate of 60 to 120 milliliters per minute. This is just the amount of filtration that your glomeruluses are able to produce when they're healthy. Just a reminder, blood pressure is the force of blood against the walls of the arteries. Blood pressure is a driving force that propels your blood through your vessels. But the amount of pressure in the arteries is going to vary based on how fast your heart is pumping, how much blood plasma you have. So if this pressure goes up, it's going to be forcing more plasma, more filtrate production to occur. And so we have to combat that to control that GFR and maintain it. Here's the afferent arteriole. Is it the entering or the exiting arteriole? The entering. And if you'll notice, the afferent arteriole is much thicker and a lot more muscles than the efferent arteriole, the exit. This is so that adjustments can be made by vasodilation or vasoconstriction of this arteriole. Say we need to decrease our GFR. That can reduce the amount of filtrate we're producing. We constrict the afferent arteriole. We have less blood flow, lower pressure, shrinks the surface area for filtration, and less filtrate produced means we have less urine. This is helpful if you have low blood pressure. Why? By decreasing our GFR, we're going to reduce the amount of filtrate we're producing, which means we keep more of it as blood plasma. So that can help us build back up our blood volume to a healthy rate. Here's the other option though. What if we have too high of blood pressure? Maybe we drank an entire gallon of water and we have got to pass some of this liquid out. We can increase the amount of filtrate we produce if we dilate the afferent arteriole. This gives us greater blood flow, which leads to higher pressure inside of the glomerulus, and also increases our surface area for filtration. Because of these things, we're going to produce a lot more filtrate, pushing it out of the glomerulus, and that increases our urine production. This is helpful if we have high blood pressure, since we can remove a lot of that volume and help bring that back down. Glomerular filtration rates are an indication of the health of your kidneys. In a young, healthy adult, we might expect to see 120 from a glomerular filtration rate. Once we start having forms of chronic kidney disease or kidney damage, that percentage starts to drop. In general, 90 or higher is considered normal. 89 to 60 is a mild loss of kidney function. You're only working at about 60% in that case. This can progress and get worse, going up in stages of severity. By the time you get to stage 4, we have severe loss of kidney functioning, and if we get less than 15%, it's considered kidney failure. Somewhere around here is when we would start to use dialysis, as we're going to have to replace the function of the kidney as it's no longer able to perform its filtration. This graph shows us our glomerular filtration rate as it's affected by the mean arterial blood pressure. If your blood pressure is too low, if it's 40, then we're not going to be able to properly produce that filtrate. But as we go up and get more to normal, say we get to an 80 mean arterial blood pressure, then we're able to have normal urine production. If the blood pressure starts to go up, by the time we get to 180 to 200, more of that high pressure is pushing the filtrate out of the glomerulus and we're overproducing our urine. So here's where your body wants your blood pressure to stay in order for it to properly filter your blood. Here's a quiz. Is their GFR decreased, maintained, or increased by the body? Let's look at a few different scenarios with some patients. Patient number 1 has high blood pressure. Should the GFR be decreased, maintained, or increased? Do, 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 do. You want to increase the GFR in this case. That way it can help remove excess fluid and lower the blood pressure. What about patient 2? They were found wandering in the desert and they're very dehydrated. Should their kidneys decrease, maintain, or increase the glomerular filtration rate? Well, if they are dehydrated, the big thing we want to do is to keep in as much moisture as possible. So if we lower the glomerular filtration rate, it's going to cause less filtrate to be produced. So we want to decrease our glomerular filtration rate in this case. Patient 3 has kidney disease and wants to know if they need dialysis. How would we know on that one? So we run the test and we determine that their glomerular filtration rate is only 30%. In that case, we need to go ahead and do dialysis because it's not occurring at a high enough level. All right, how exactly are we taking filtrate and producing urine? We touched on this a little bit. Your filtrate is full of glucose and electrolytes that we need to remove and take back into the body, leaving just the waste in the filtrate. That way we can concentrate the waste and create urine. These red capillaries that wrap around the tubes, they're the ones that are going to do that reabsorption. Step 1 is going to be glomerular filtration. That is when we take the fluid, we filter it out of the glomerulus into the capsular space of the Bowman's capsule. Water and its dissolved substances, the ions, the glucose, plus tiny particles can pass through the capillary pores. This produces filtrate that contains water, nutrients, waste, and electrolytes. The filtrate will enter the tubes, the proximal convoluted tubule, the nephron loop, and the distal convoluted tubule. The capillaries that wrap around the tubules are going to reabsorb nutrients, electrolytes, and water as needed to maintain homeostasis. We also have what is called tubular secretion. This is when substances the body needs to remove can move from the capillaries into the tubules by active or passive transport. These include hydrogen ions, drugs, urea, etc. So here we have glomerular filtration. The filtrate enters the tubules. Tubular reabsorption occurs when substances move back into the capillaries. Tubular reabsorption occurs when substances move back into the blood. This is what we want to keep, so our glucose, our nutrients. On the other hand, there are some substances that did not get filtered out in the glomerulus, but we still want to get rid of them, like the urea. So we'll active transport or passive transport send that into the tubules. Later on in the descending limb, different things will be reabsorbed and secreted. Same thing for the ascending. These different cell types lining the tubes are going to allow different substances to be reabsorbed or secreted in the distal convoluted tubule and the collecting tubule and duct. So the whole time we are reabsorbing and secreting. Reabsorbing and secreting. The vast majority, 99%, of what is filtered out of the glomerulus will be reabsorbed by the capillaries. 180 liters are filtered out each day, but only 1.5 liters of urine are produced. Substances that are reabsorbed completely include nutrients like glucose and amino acids and those small proteins. We have regulated reabsorption of things like water and ions such as sodium, calcium, potassium. All of those electrolytes, we're going to control how much we reabsorb based on how much you currently have in your body. Helps us to maintain that homeostasis. Substances that we eliminate as waste include nitrogenous waste, drugs, and some hormones. Tubular transport is when substances move across the tubular walls. Paracellular transport is when it moves between the cells, so little gaps in between the cells have just enough space for some substances to travel through and then get reabsorbed by the capillaries. Transcellular transport is when we have transport proteins on the cells that are going to take something from the inside of the tube and pump it out, or vice versa, pump something back in that goes into the tube. Thus, it can be transported between the cells or through the cells. The transport pumps are going to be different in the proximal versus the loop, thin and thick, and the distal, and the collecting duct. So because of that, different things will be absorbed in different sections of the tubules. In the proximal, we're going to have the majority of the reabsorption. We're going to reabsorb water, ions, glucose. Most of that is getting reabsorbed in the proximal. Inside of the loop, we're going to have about 10% of our reabsorption. So some water, some ions. And in the distal, that's where we're going to have the regulated reabsorption of water and ions as needed. Let's use the example of potassium. 60 to 80% of your potassium is going to get reabsorbed in the proximal convoluted tubule. About 10 to 20 could get reabsorbed in the loop. And then a small amount of regulated potassium reabsorption can occur in the two collecting tubules, whereas certain type A cells are going to reabsorb K, and principal cells vary the amount they secrete. So your levels of different hormones like aldosterone can control how much potassium you secrete here. Now water is a little different. We see 65% of it being reabsorbed in the proximal tubule, about 10% happening in the nephron loop, and then some regulated water reabsorption traveling through here. This is the lumen of the collecting tubule, and we have small aquaporins that transport water across the principal cells back into the capillaries if needed. The hormone ADH can increase the number of aquaporins that we have in use, resulting in an increase of water absorption. That's how the hormone ADH could increase your blood pressure if it keeps more of that water in the body, doesn't let it go into the urine. Instead, it builds up in the blood plasma. Now, secretion is also happening. Excess hydrogen ions and nitrogenous waste can be secreted into the tubules. Urea can be secreted into the loop. And the distal convoluted tubule in the collecting duct is where we can secrete potassium as needed. So by the time it gets to the collecting duct, we're going to see that uric acid, the bicarbonate, the creatine, the potassium and sodium and chloride, and the urea. So everything the body doesn't want, we're going to send out through the collecting duct, and we've already reabsorbed everything we needed. What happens when your kidneys fail? Dialysis may be used to basically replace the function of a kidney. This entire machine can do the function of a kidney. You think that's not very large? You can hold a kidney in your hand and look at the size of the machine designed to do the same function. To replace a kidney function, you're going to need about 4 hours of dialysis 3 times a week. And eventually, this still can't compete with a kidney that runs 24/7. So you eventually are going to need a new kidney. Hemodialysis is when we take your blood, run it through a machine that filters out and cleans it, and then gives it back to you. This is a pretty painful process, and most patients do not enjoy this. It's painful. It leaves them very tired, and they kind of dread going to dialysis. So then you look at needing that 3 times a week, and that can be a very painful situation. Hemodialysis was what we just saw. It's when your blood is removed from the body and cleaned with a machine. An alternative that allows you to do the dialysis at home is called peritoneal dialysis. This is when blood is cleaned within the body rather than removing it. Your abdomen is filled with a solution through a catheter. We're filling the abdomen up with this fluid. Then we allow it to sit for a certain amount of time. The waste is going to naturally go into this fluid, and then we're going to remove the fluid. Here we see blood coming from our patient, full of waste. This is the renal artery. What do we see over here? The clean blood that returns to the patient. That's the renal vein. What does this do? It replicates the nephron. Here we see the glomerular membrane. This membrane keeps all of the red blood cells and white blood cells traveling on and allows the waste to leave, where we send it into a used receptacle. This would be our ureter and our bladder. All right, that is it for the urinary system. That was a pretty long, detailed PowerPoint, so congratulations on getting that done. And you are almost done with this class. We just got a couple more chapters to go. Keep up the good work.